We're going to be talking about the fascinating topic of ventilator management. To attempt to learn by lectures only is idle and unprofitable. Take them as guides to direct your observation, your reading, your meditation. But to suppose that the mere listening to lectures should confer excellence would not be less futile than for a traveler to bestride a guidepost and vainly expect that it should, without effort on his part, convey him to the destination to which it points. With that said, I'm going to give you a lecture. And the objectives are to cover the topic of ventilator breaths, ventilator modes, ventilating ARDS, ventilating an acute obstructive airway disease, typically asthma, with COPD, metabolic acidosis, and then some troubleshooting. And my main goal is to walk away with a vocabulary, how to approach a ventilator, how to have a terminology and a common language, and to get some comfort with your rounds in the ICU, down in the CCT, and then obviously for inspiring some future discussions and taking it to the next level. This is the time frame of a critically ill patient that's intubated. And we spend a lot of time talking about airway management and all the details that go into getting that airway as safely as possible. And we pivot immediately to immediate post-intubation care and all the things that we do in that aftermath, 30 minutes, 45 minutes. And then we have all the continued critical care, some of the topics that Dr. Conrad just discussed. And then ultimately we have to have a discussion about what's the ultimate resolution. Are we extubating a patient with the goal of rehab and recovery? Is the patient getting a tracheostomy? Or are we pursuing more of a palliative approach and comfort care? So why do patients require mechanical ventilation? It's because they're intubated. So then it goes back to the question of why we intubate patients. And this is the same exact slide from the lecture on airway management. So why do we intubate patients? Because they have an airway issue. So something's going on with the airway itself. Epiglottitis, dynamic airway obstruction, that rare acute anaphylaxis with airway obstruction, severe angioedema, anything that's going on with the airway. And then you imagine that patient, that's not going to be a straightforward airway. That's an anatomic difficulty. It's going to be an anxiety-provoking. They're all anxiety-provoking, but a particularly anxiety-provoking airway. But afterwards, there's nothing necessarily wrong with the lungs. So assuming all those other things are okay, ventilating that patient will not necessarily be a challenge. And if ventilating that patient will not necessarily be a challenge, then all the sedation requirements also, assuming there's not a lot of anxiety, may not necessarily be required as well. Breathing, all the breathing issues. These are problems directly associated with the lung. So your status asthmaticus, severe pneumonia, hypoxic respiratory failure. These are problems that are directly related to the lung. Hypoxic type 1 respiratory failure, hypercapnic type 2, and then mixed and type 4. Airway management may be straightforward. The physiology will be difficult if we're talking about hypoxemia. But then ventilating the patient, this is the group of patients that are very difficult to ventilate. These are the group of patients, the ARDS, hypoxic respiratory failure, that we're potentially sending to LSU for a VV ECMO consult. And so then all the stuff that goes along with that, if they require a lot of that vent management and it's challenging, maybe also some higher sedation requirements. This is going to be the focus of our talk. Circulation, shock, metabolic acidosis. Some of these patients are also going to be difficult to ventilate. Airway management physiologically may be difficult. If you think about the fear of intubating a severely acidotic patient, think about that. But the ventilator management has some nuance, and we'll discuss that. Disability, these are all of our neuro patients, severe traumatic brain injury, severe stroke, CNS depression because of tox cases. Airway management may be straightforward. Ventilator management may be straightforward because there's nothing necessarily wrong with the lungs. And then sedation requirements may not be as high because remember what got us intubated in the first place. E is expecting A through D, and then F, sometimes this happens where a patient's freaking out and we need to intubate a patient to take care of them. That's not what we're going to be talking about. So we intubated the patient. Everything went okay. And now you got your patient here. They're on the ventilator. They're getting their sedation. They're getting their fluids. They're getting their antibiotics, their blood products. But we have to approach the ventilator. So how do we approach the ventilator? Initial ventilator settings. Things that we have to talk about. Mode. What does it mean? Tidal volume. What is our goal? Respiratory rate. What is our goal? PEEP and FiO2. And if you break it up into two things, tidal volume and respiratory rate is all about ventilation, minute ventilation. In fact, the product of the two is exactly that, minute ventilation. PEEP and FiO2 is all about oxygenation. And we have to think about our targets. When we approach the ventilator, what are we going to be targeting? When we deal with a patient in shock, we have blood pressure and hemodynamic targets. When we're dealing with respiratory failure, we have gas exchange targets. So we're looking at the blue number, the pulse ox, and I put it's 100%, but that's not necessarily always our target. That'll vary. End tidal CO2, again, we have certain targets with that, and that'll vary. And these are non-invasive ways of looking at gas exchange. But remember, we also have our invasive arterial blood gas or venous blood gas looking at gas exchange. And we're trying to come up with ways to not necessarily normalize those numbers, but to ensure that they're as adequate as possible to continue to sustain life for that specific patient. Because again, if we try to normalize these numbers, we may actually cause harm. And we're trying to do all of this while not affecting the hemodynamics as well. Remember, the lungs and the heart, they're in the same cavity, so there's a lot of interactions where if you perturb one system, you could potentially perturb the other. These are my notes when I was first learning about ventilators. I took a picture of them. These are actually my first notes. I sat with a fellow in Kings County MICU. This was about, I don't know, I was a PGY2, and I was like, break this down for me. I don't understand what I'm doing. Help me understand what's going on. And the fellow at that time, she broke it down to me by starting out with not necessarily modes, but what is a breath? What are the different kinds of breaths? And so when you approach a ventilator, take a look at each breath before you even look at the mode and ask 3 questions. What are the 3 T's of each breath? What is the trigger? What is the target? And what is the terminator? And there's a couple of different names for these 3 T's, but if you think about that, the 3 T's of each breath will help you understand what you're looking at when you look at a ventilator. The trigger. Is it the ventilator? In other words, the patient is completely passive and they can't initiate, they can't trigger their own breath. Then it's a controlled breath. There's going to be a C. If it's targeting the flow, and if it's going to terminate once that tidal volume is reached, that's a volume control breath. It's a VC breath. If the trigger is the patient, in other words, they're not completely paralyzed or sedated and they're able to participate and they trigger their own breath, it's an assisted breath. So the patient triggers it, so it's a VA breath, VA. The target in PC is a pressure. And the trigger, again, depends if the patient is passive, if they're completely sedate, or if they're active, if they're able to initiate their own breath. So when you take these 3 T's and you fill out this table, you can create these 5 different breaths. A volume control breath where the patient's completely passive. The ventilator, you put in 10 breaths per minute. Every 6 seconds, the ventilator will trigger a breath, will achieve a target flow, and will cycle into expiration once that tidal volume that you plugged in is reached. If the patient wakes up a little bit and is now able to participate, you put in 10 breaths, but the patient's breathing at 14. Some of those breaths will be triggered by the patient. Some will be by the ventilator. So there'll be 2 types of breaths there, a volume control breath and a volume assist breath. Both of those breaths will look identical. The only difference is who triggered that breath. The same is true for the pressure control and the pressure assist breaths. The only difference is what is the target. Where the top, it's cycling after the volume is reached. Here, it's cycling after a certain time spent at that pressure. And then the PS, the spontaneous pressure support breaths, are the patient is triggering, they're achieving that pressure at a certain amount of time, and then it cycles once a certain flow or fraction of a flow is reached. So we're going to try to make sense of these things and look at how it applies to those ventilator screens. But these are just breath types. Those were my notes. This is just a nicer table of exactly that. So that fellow was spot on in breaking it down for me in that way. Breath types have a trigger, a target, and the cycle is just another word for the terminator. Volume control breaths, volume assist breaths. That's when you plug in the volume. Who's the trigger? Either the ventilator or the patient. Pressure control breaths or pressure assist breaths. You plug in the pressure. Who's triggering it? Either the ventilator or the patient. And then the support, pressure support, the patient does almost all of the work. Rebel EM has a really nice link on ventilator management. And I would urge you maybe after today to go take a look at it. It's a really good read. It's a really brief read, but it breaks it down beautifully with diagrams because I until today, it's like just a hard topic. And I always have to like look for really cool diagrams, even to remind myself of what I'm talking about. And a controlled breath, which we just talked about, is basically the ventilators doing all the work. The patient can't do any work. They may be paralyzed. So maybe us preventing them from doing any work. Or they may be completely obtunded or just frankly deeply sedated, so they can't do any work. Not a good idea to keep a patient like that because then they'll atrophy, the rehab will be long, the course will be long. But sometimes they need it. Up front, that may be necessary. The assisted breath is the patient, remember, triggers the breath, but the ventilator says, no, I got you. I'm going to take the rest of it. I'll give you the rest of the breath. All right. The patient must be able to trigger that breath for the ventilator to assist. But the breaths themselves on the screen will look identical. The only difference is the patient triggered this one, the ventilator triggered that one. The supported breath, patient's much stronger, right? This is at the end of their course in the ICU where we're talking about doing spontaneous breathing trials. They initiate the breath. They do almost all of the work. They get a little bit of support. That's that gym device where you're doing pull-ups on the whatchamacallit. So again, those were all about breath types and how much work the patient is doing and how much work the ventilator is doing. Taking those breath types and laying them out over time tells you what mode you're actually plugging into the ventilator. So if you have a volume control and a volume assist, that's VC-AC ventilation, volume assist control ventilation. The patient will be getting those two breaths and you're getting that tidal volume that you want. You can guarantee that minute ventilation. The pressure assist control, the patient is triggering the breath and the ventilator is triggering the breath. Only difference is now you're targeting a pressure. Pressure support at the end of the course, more related to the inpatient care. Patient's triggering the breath, gets a little bit of support. That's that pull-up in the gym, and it'll cycle off on its own. And then we'll talk about how those breaths can be combined to make up those two other modes at the bottom, SIMV and PRVC. When you go to the ventilator upstairs in the unit and you actually click that button, modes, it's going to open up a table there where all those modes that we just discussed that are consisting of all of those different breath types, and you can pick which one you want. So the controlled modes, pressure control, volume control, PRVC, which we'll talk about, which is I think the most commonly used mode upstairs, APRV, which we'll talk about, and then the supported modes, PS CPAP, pressure support CPAP, which has those spontaneous breaths. And there's a couple of other ones there. The SIMV we'll try to make sense of too. But those modes are basically just consisting of those breath types. So what is this when you look at a screen? What are you actually looking at? These waveforms, they have a name. They're called scalars. They're called scalars, and that's to distinguish them from loops. And it's almost always the same format. The top is pressure, the middle is flow, and the bottom is volume. And I'll show you different ventilator screens just to show you that it's almost always the same kind of setup. And you'll get comfortable with the waveforms because when you approach them, it's always pressure at the top, flow in the middle, and volume at the bottom. You see the settings, which you plug in, and then based off of what's going on with the patient, you see what you get out of it on the side. So this is what you put in, the independent variables, and then what you get out of it is the dependent variables. And the waveforms are essentially a reflection of that just in a waveform scalar format. So you see how at the top it says VCAC? It's because it's controlled breaths and assisted breaths targeting that volume. Volume control typically has a ramp up like appearance in the pressure scalar, and it's a square waveform in the inspiratory flow. So inspiration, and then it cycles into expiration. Expiration is passive, so expiration is always going to look the same in all of these modes. The only difference is the part that is the inspiration. So VCAC has that look, almost looks like a shark fin. I'm saying that on purpose because I'll quiz you afterwards, and you'll be able to tell which mode you're looking at. This is volume control. Here's another fun fact. The ventilators, if they're made from different models, will take the same exact ventilator mode and call it something a little bit different. So here it says volume control, but it may be VCAC. So this is why if you just break down the waveform itself, you can tell what you're looking at. So again, it's going up in a shark fin-like thing. It's a square waveform inspiration. You're targeting that tidal volume. The only difference is here. Anybody know what's been done here? Correct. An inspiratory hold has been pressed. And what that does is it just holds the inspiration a little bit longer and creates this pressure called the plateau pressure. And that's how you detect the plateau pressure. So it's just pressing inspiratory hold. And then it cycles into expiration, which again is passive. Again, you've got everything that you put in here and then everything that comes out there. Your dependent and independent variables. PCAC looks a little bit different than VCAC. PCAC, remember, you're controlling the pressure. So the pressure itself is going to be constant. It's going to look more square-like up top, the pressure scalar. And then in the middle, the flow is no longer a square inspiratory flow. It's a decelerating flow. It's a decelerating flow. So it looks a little bit different than that VC. So we'll put them side by side, and you'll be able to tell the difference between VCAC and PCAC. And then the volume. So pressure, flow, and volume. Bottom, everything that you put in, everything that you get out in numerical format, and then everything in a scalar waveform format. This is what they look like side by side. Which one is volume? Which one is pressure? Volume, pressure, right? Volume ramped up, square waveform. Pressure control, square, decelerating flow. And the expiration part looks identical because it's all passive. So volume control on the left, pressure control on the right. And this is what they look like on the actual ventilators. Volume control, ramp up, square inspiratory. Pressure control, square pressure, decelerating flow. Right now, you can't tell if a patient's triggering the breath or the ventilator is triggering the breath. So you know that all those breaths are the same. You just don't know yet if it's a trigger by the ventilator or the patient. It looks like they're spaced out about the same amount of time. So it could be that this is just VCAC at 12, and this is PCAC at 12. And maybe the patient is just very passive. When a ventilator looks this pretty, it typically means that the patient is very passive. They're not very interactive. And what I mean by interactive, sometimes they get agitated and very interactive. They're very uncomfortable. The waveforms will look almost like an EEG or an EKG. So the point is we're starting with patients that are very passive. They're comfortable. This is the immediate post-intubation when they're under the influence of rocuronium, hopefully with some sedation. PRVC. So what's the difference between PRVC and VCAC and PCAC? PRVC is taking PCAC and only saying to the ventilator, you're a pressure control mode, but each breath, I do want you to actually guarantee that tidal volume. So it's as if there's like a little respiratory therapist in the ventilator saying, okay, I'm going to do PCAC, but I'll let you tell me to actually achieve this tidal volume. Because remember, in pressure control modes, you're not guaranteeing the tidal volume, right? If the patient's lung disease gets worse, their compliance goes down, their tidal volume will go down if you keep the pressures constant. PRVC says, you know what? We're going to account for that change in disease, and we're going to say pressure control, assist control, but if you want me to do tidal volume of 400, I'll do it. And so actually, if you think about it, if the disease course changes and the compliance changes, you may see breaths that look identical, only at different amplitudes. One breath may require a little bit more pressure to achieve that same tidal volume. The compliance improves. The next breath, maybe the pressure that's required is a little bit less to achieve that same tidal volume. So the tidal volume should be almost, that target, but the pressures may be higher and lower in PRVC. So it's as if the pressure control, assist control, is just adjusting itself on a breath-to-breath basis. What mode is this? Just shout it out. It's okay if you get it wrong. VC, why? Because it's a square inspiratory flow, shark fin up, and then the tidal volume gets no glory. It's just the tidal volume. What mode is this? Shout it out. Pressure, because it's a pressure square waveform. That's the control. Decelerating flow. This is the variable. What mode is this? Yes, it's PRVC. Why? Because it's basically PCAC trying to target a tidal volume. So the ventilator is adjusting those pressures on a breath-to-breath basis in order to achieve those tidal volumes. Doesn't quite make it here. That's probably what it's trying to achieve, and it's checking itself on a breath-to-breath basis. So it's still square pressure, still decelerating flow, with the volume finally getting to what you plugged it in. So it looks different than VCAC, looks almost identical to pressure control, assist control, but it's just adjusting itself. This is extra credit. What mode is this? We talked about it. The patient initiates the breath. It's square. It's cycling at different flows, some short. This is pressure support, CPAP pressure support. This is what that looks like. The patient is given the same amount of support, but the patient is spontaneously breathing and has control over how long they want to breathe to a certain degree before it cycles into expiration. And so you'll get the same pressure difference. That's the PS, the pressure support CPAP part, but the flow will be where the patient determines when they cycle off. And so the volumes will be a little bit different. This is a spontaneously breathing patient. And don't worry, we'll go over that one more time afterwards. So what mode is this? This is APRV. APRV, I want you to think of as like the patient is on CPAP. What do they plug in here? At 20. CPAP 20. They're just breathing at CPAP 20. And they're spontaneously breathing. Like when you do a CPAP pressure support trial, they're spontaneously breathing. Only instead of having a CPAP of 5, you have a CPAP of 20. So that's what APRV is. Only every 5 seconds, you cut the CPAP for a split second, and then bring it right back up to that same CPAP. So it's CPAP with little intermittent breaks. And the patient is essentially breathing up at that CPAP. I want you to take a second to imagine what this feels like. Take a deep, deep breath. And don't completely exhale. And take smaller breaths on right at where you are right now. Imagine being intubated with a central line in your neck, an arterial line in wherever it's placed, on ECMO. You have a fever and soft restraints. And you're banging the side, and there's a code next door, and the ventilator alarms are ringing, and you have an NG tube in your nose. Just think about that for a second. But that's what APRV is. It's supposed to be actually the more comfortable mode, believe it or not, to reduce the sedation requirements. But actually think about this stuff sometimes, and we'll simulate some of these ventilator breaths. But it's CPAP up top. Sometimes we go up to 30, and every 5 or so seconds, 4 or 5 seconds, and there's rationale for that. There is a, There is a P high that you leave the patient at. There's the P low that you release that CPAP for. There's a T high that you keep the CPAP, the P high at, let's say for 5 seconds, that's your T high. And then there's a T low, let's say 0.5 seconds. A common ratio that's used is 90% and 10%. 90% of the time spent at the P high, 10% of the time at the P low. And that's how you put in those settings. And then the FiO2 is what you adjust. And that's what your input is in here. And that's what your output is at there. But again, Pressure, flow, and volume. Pressure, flow, and volume. It's the same exact setup. The good physician treats the disease. The great physician treats the patient who has the disease. Here's a case. I'm going to refer this case to you. 55-year-old male, intubated with hypoxemic respiratory failure due to influenza A. Blood pressure is 140/90, heart rate's 120, temps 101, SATs 82%. And all of this is obviously despite being intubated with a central line, and those lungs look like that. This is hypoxic respiratory failure. This is ARDS. And ARDS is actually an interesting condition. First described in 1967. The same year, respirator lung was described. Respirator lung is discussion of ventilator-induced lung injury. 1967, both conditions first described. This is the actual case series of the first description of ARDS. And if you take a look, even back then, they were talking about fluid overload as a possible association with ARDS. But you look at all these other causes, polytrauma, acute pancreatitis, viral pneumonia, Guillain-Barré, crushed chest. ARDS, described in 1967, fluid overload, defined first in 1994 and then adjusted in 2012, and there's some recent guidelines, but really it's a syndrome, and that's really the important part. It's a syndrome, it's a collection of criteria that arrive at the diagnosis of ARDS. So it's not a specific disease, it's a syndrome. And the point I'm trying to make is that when it's not a specific disease, there's not a specific treatment. There's just a lot of general treatments. I think that's what you're alluding to. A lot of general treatments aimed at supporting a patient through this condition while specific treatments are provided for the underlying cause. So, timing. Within a week of a clinical insult, one of those reasons, chest imaging that meets the criteria, bilateral opacities, it's not cardiogenic, and it has various severities. And we're not going to be talking about ARDS, we're just going to be talking about ventilation management. ARDS ventilation. This is the ARMA trial. This is back in 2000. And really, this is a landmark trial in critical care and emergency medicine about ventilating at low lung volume as compared to high tidal volumes. And again, going to the key crux here, when I emphasize that it's a syndrome and we're really trying to prevent ventilator-induced lung injury, one of the criticisms of this is perhaps what we were doing is not necessarily saving lives, but avoiding death. So by avoiding higher tidal volumes of 12 mLs per kilogram and above, maybe we're just preventing harm rather than saving lives. So really, maybe this is a trial of avoiding ventilator-induced lung injury, one criticism. But really, the main takeaway is 31% mortality versus 39, both high, but 6 mLs per kilogram predicted body weight versus the higher than that, 12, improved mortality or prevented death, prevented harm, prevented ventilator-induced lung injury. And ventilator-induced lung injury is essentially barotrauma, high pressures, high volume, volutrauma, opening and closing of alveoli, so atolect trauma, and then the inflammation that's caused, so biotrauma from the ventilator-induced lung injury, independent of all the other things that you're doing on the ventilator. So we're always balancing avoiding ventilator-induced lung injury and accepting sometimes not ideal gas exchange. So this is the concept of permissive hypercapnia. We're not trying to normalize things. We're trying to identify a goal on a specific case-by-case basis and then managing risk and benefit and avoiding harm. First, do no harm. It's VCAC. It's a ramp, shark fin, square waveform inspiratory, passive into expiration. The tidal volume right there, if we have a patient in ARDS, like the case that we started with, we're trying to go for 6 mLs per kilogram predicted body weight. So make sure you know what that predicted body weight is for your patient. And that's where that number comes from. And then the other output that we get, right? This is now an independent variable because it's VCAC. We plug in, we have to look at what the patient is giving us back. And that's in the form of the pressures, right? If there's a low lung compliance because both lungs are just taken out by ARDS, the pressures will tend to go high. So how did we get this? Like we said earlier, we did a brief inspiratory hold and we generated a plateau pressure. And one of our targets is we want that number less than 30. Like we just said, once it goes above 30, mortality goes up. So we want that number less than 30. So tidal volume is important. PEEP. PEEP's another important number. And what about PEEP? What is it about PEEP? When you have a patient in ARDS, you see the lungs on both sides, the disease is heterogeneous. It could affect lungs very differently in different parts of it. And so you can break the lung up into parts depending on what is going on an alveolus basis. Lungs that are alveolar units that are completely collapsed may be recruitable versus the alveoli, let's say at the top, which are participating in gas exchange, which are at risk for harm by overdistension, versus the lung segments in between that you're trying to balance atelectatic trauma and overdistension. So you have to find where your patient is, and not every ARDS patient is going to be the same, right? And not every patient has the same reserve. So the disease is going to affect a patient differently. And so how you adjust the ventilator will be on a case-by-case basis, and you have to try to troubleshoot through trial and error what is the optimal PEEP. So below, there's a recruitable lung where you could recruit by going up on the PEEP, but if you go too high, you run the risk of overdistending and causing barotrauma and overdistension and ventilator-induced lung injury. And there's all these trials on just that single button, that single dial, PEEP. Look how many trials, and this is just like a selection, and I put it on purpose in a staircase format because there's trials on even performing staircase-like PEEP maneuvers on how you should adjust the PEEP. What is the best way? And there's some arguments about what the best way is. Should you go up to a PEEP of 20? Should you leave the PEEP at 5 and slowly go up? Should you perform something called a recruitment maneuver, which is just taking that PEEP button and pressing 20 or 30 and leaving it there for 20 to 30 seconds? And the signal from all of this is essentially, if you need to apply PEEP because your patient is not oxygenating, you can, if your patient has severe ARDS, err on the side of higher PEEP, but we're talking about in the range of 15 to 20, 22, 24. Or you can do lower PEEPs for your milder patients. And then if you need to adjust, you can go up typically, and this is really more of an art of medicine, increments of 2 to 5, and then see what your pulse ox is doing. But you can cause some harm if you go too high. It can cause cardiovascular collapse because remember, the PEEP occupies a huge segment of that respiratory cycle. So if there's a lot of time there, that means that the pressure in the thorax is high. That means that the venous return is going to go down, and you can cause cardiovascular collapse. That other pressure in VCAC, the difference between the plateau and the PEEP, something called the driving pressure. And this is actually a really interesting trial that was done that looked at the driving pressure, the difference between the plateau and the PEEP, and saw that a number of 15 seems to be, a difference of 15 between the plateau and the PEEP seems to be that sweet spot where you want to keep it less than that. And if it starts to go higher, you may actually increase mortality. So here's a graph where the driving pressure went up, and so did the mortality. The driving pressure went down, and so did the mortality. And when it was kept constant, it didn't change. So again, just another thing to look at on the ventilator when you're looking at the PEEP and the plateau pressure, about if that number is getting too high, you may be running into that area of overdistension. So at the top left is just essentially the lower PEEP and higher PEEP tables from the ARDSNet trial. And really, this is just usually what I still stick to because it's actually the only trial that shows a significant mortality benefit. So I stick to that, just bare bones, keeping it simple. The patients are really sick, severe ARDS, the PF ratio less than 150. I err on the side of the higher PEEPs. We're talking about this range, and then adjusting the FiO2 down if possible, versus the milder patients, milder ARDS, starting with the lower PEEP. This is just a nice table here that came out of MGH during the first wave of COVID when everyone was trying to figure out what to do. And I really like this about how to, at the bedside, look at all these different variables and seeing what they do to the hemodynamics and adjusting the PEEP and the driving pressure. So the PEEP going up in increments, what does it do to the plateau? So if you go from 5 to 10, did the plateau pressure go up a little bit? Okay. If you went up another 5, did it go up? Okay. If we went up a little bit more and it really starts to go up, you're starting to reach an inflection point of overdistension, that top of that curve. And you know that your compliance is starting to go down. And the driving pressure, once you hit that sweet spot, is probably right at its own inflection point. Once you start going over that, you also start to see the impact on the hemodynamics, and the pulse ox starts to go down because you're over distending. So just a nice way where you can go up in increments, look at your plateau pressure. Is it going up at a relatively smaller increment? Looking at your pulse ox, how is it responding? And then also looking at your driving pressure. So what about APRV? APRV, you can adjust the pressure high, the pressure low, right down there. Those are two settings. The time that's spent in each, and the FiO2. And there's different schools of thought in terms of when to apply APRV. Should you just start with APRV, or should you use it as a salvage therapy in order to avoid considerations for VV ECMO? And there are some small trials that look at conventional ventilation compared to APRV and find some benefit in terms of days on the ventilator, no real big mortality difference. And then there's people that are just diehard, I'm going to do APRV, and that's how I was trained. And I think it's about balancing all of those things, getting exposure to APRV while balancing it with the evidence and applying it on a case-by-case basis. If you think about APRV, it lets the patient spontaneously breathe because it's CPAP, just taking a few breaks like we discussed, but it's also subjecting the thorax to higher pressure for a longer period of time. So you have to make sure that the patient can tolerate it from a hemodynamic perspective. What do you think it's doing to the afterload of the RV? Is it going up or going down? It's going up. And actually, sometimes these patients will go into RV failure. So something to be aware of. So it's not really the perfect PE patient or pulmonary hypertension patient to utilize this mode. But it is going to recruit a lot of lung. And sometimes the X-ray all of a sudden can miraculously look just a lot better. But then that begs the question, was that patient actually an ARDS, or was it fluid hydrostatic pulmonary edema? So this is usually utilized most often when the patient is still hypoxemic despite those conventional modes in ARDS, in addition to some other things like proning the patient and doing some other things to try to really recruit as much lung as possible. Here are just some initial ventilator settings to get things started when you have your hypoxemic respiratory failure patient. Range of 4 to 8 mLs per kg. Predicted body weight, start at 6. If the plateau pressure is above 30, by doing that inspiratory hold, go down by 1 milliliter per kilogram in the tidal volume. Adjust your respiratory rate based off of the PCO2 and pH. And then keep an FiO2. Look at your pulse ox. What's your goal? Is it 88 to 92 or 92 to 96? You don't need 100%, but decide what your goal is, and then you could adjust your PEEP based off of that, and then go down on your FiO2 as tolerated, just to get things started for your hypoxemic respiratory failure patient. You just intubated. Make sure when you get the blood gas, if the PCO2 is 60 and the pH is 7.25, that may be perfect for that patient, that we don't start adjusting things and then running into causing harm. Observe, record, tabulate, communicate. Use your 5 senses. Learn to see, learn to hear, learn to feel, learn to smell, and know that by practice alone, you can become an expert. 40-year-old female, intubated for status asthmaticus. This doesn't happen very often anymore. pH, post-intubation 7.1, PCO2 is 80. With asthma, I mean, we're trying to do everything to avoid intubating the patient. Rarely, it's a must. And then here, the issue is not necessarily with the lungs themselves. The compliance may actually be increased, but the airways themselves. And so when you go back to that pressure waveform, again, it's a ramp up, almost shark fin. So it's a pressure control or volume control. Volume control, breath. And here, when you do that plateau pressure, the difference between the peak inspiratory pressure, PIP, and the plateau pressure is going to be high. Normally, that difference is supposed to be less than 5 centimeters of water. Here, it's really high because there's a lot of resistance. The ventilator has to overcome the airway resistance in order to deliver that tidal volume. So normal on the right, severe asthma on the left. And again, the patient is pretty passive. That's why it looks like that. The other real main issue as a result of this is that now the patient can't fully exhale. And so remember the expiratory flow, that second one in the middle, it's passive. Expiration is passive, but it's supposed to return back to the baseline. And that tells you that the volume of air in the lung has been completely exhaled. If there isn't a return to baseline, that means that that volume from that prior breath is still in the lungs. And so the next breath is just going to add to that. So you're going to get something called breath stacking. So on a ventilator, what does it look like when you have a really bad COPD or asthma patient? By the way, what mode is this? This is flow. How did you know it was volume? Thank you. Square waveform. Square waveform inspiratory, so it's volume. These are both flow. This is the middle of the ventilator, right? Pressure, flow, and volume. Inspiration, but expiration is passive. This is normal. Expires, returns to baseline, fully exhaled, next breath. Inspiration, expiration. This is what it looks like when you have a really bad status asthmaticus. That peak inspiratory flow, it goes down really, and it creates this like sharp divot, and then it's slow to exhale and doesn't return to baseline. So this next inspiration just got added to this. So that's going to cause some breath stacking. Another way you can, breath stacking is going to add and lead to auto PEEP. Auto PEEP. How do you detect auto PEEP? How do you detect the plateau pressure? You do an inspiratory hold. Auto PEEP, if the patient is really passive, which they probably should be if you just intubated them for asthma, you're going to do something called an expiratory hold. And an expiratory hold occurs at end expiration, and it goes up, and it gives you a total PEEP. So the auto PEEP is going to be the difference between the total PEEP and the PEEP you actually plugged in. So if the PEEP you plugged in is 5 and you got a total PEEP of 16, that means there's some auto PEEP of about 11. And auto PEEP isn't good because auto PEEP is just going to get worse if you don't address it. Sorry. Oops. If you don't address it, this is what happens. Each breath is going to stack and stack and stack, and then the patient is not going to be able to take another breath despite what the ventilator is doing. One other fun factoid for examining the patient, if the patient has wheezing and they're still wheezing when the next breath starts, they're auto PEEPing because they were still wheezing. That means that they were still exhaling. That means they didn't actually reach the end of exhalation before the next breath. You arrive at the patient in the CCT room 5, the ventilator's alarming, he's bradying down, blood pressure is starting to go down. What should you do when you think it's auto PEEP? Anybody? See a lot of hand motions. Everyone's doing an interpretive dance. Disconnect the ventilator, I think is what I'm getting, and press down on the patient, help them exhale, reconnect them, but don't reconnect them at the same ventilator settings. You have to make an adjustment because it's going to happen again. Asthma settings for your ventilator. Again, the mode hasn't changed. It's still VCAC. That's a nice just way to start. Nice way to start. Keep it simple. 6 to 8 mLs per kilogram predicted body weight. 8 to 10 breaths per minute. Let the patient exhale. If you do 8 to 10 breaths per minute, let's say you do 10, that's every 6 seconds. If the patient's really passive because you just gave them rock to intubate them, I have my bias. Every 6 seconds, the ventilator will trigger the breath. If you allow them to inspire for a second, that means that for 5 seconds, they'll be expiring. That's a 1 to 5 or 1 to 4 I to E ratio, which is probably good to let them expire. Watch your SAT, pick your SAT target, which may just be 94 or 93 or 92%, your PEEP of 5, and monitor for breath stacking. Look at that expiratory flow. Is it returning to baseline? Is the patient becoming hemodynamically unstable? Are they still wheezing before the next breath is being delivered? Is there signs of auto PEEP? And if there is, make some adjustments while you're treating their asthma. Last case, 24-year-old male, severe DKA, becomes obtunded from respiratory fatigue. This is their pH, 7, less than 7. PCO2 is 20, bicarb's 4. Not good. You're doing the fluids, you're doing the insulin, you're doing everything great, but this patient today is here to be intubated. There's no arguing. It's an intubation ventilation lecture. Yeah. What is your goal for the PCO2? So just going back, this patient's decompensated. I can tell you right now they are. Why? Because the pH is less than that and the PCO2 is that, and they're obtunded. They're not compensating, okay? and they're not going to compensate because you can't make the PCO2 zero. It's not single digits, and that no matter what you do, they're going to eventually lose their respiratory drive and really just decompensate. So there's a goal, and the goal is that Winter's formula, going back to the Winter's formula, the goal PCO2, where you want them to be compensating so that their acid-base status while you're treating them with insulin and fluids is improving. So, it's 1.5 times the bicarb. So that patient would have been 1.5 times 4 is 6 plus 8 is 14. So 18, 16. So a little bit of help. This is just a nice little thing. Again, I got this from the Rebel EM. It's a nice ballpark figure. If you want their goal CO2 to be that's the minute ventilation goal. So if you think of what constitutes the minute ventilation, it's tidal volume times respiratory rate. So your tidal volume, still making sure that you're doing the 6 mLs per kg times the respiratory rate. If that's what you need, it ends up being sometimes like a respiratory rate of 30, 35. And then watch for all the potential harms of auto PEEP and breath stacking. 8 mLs per kilogram predicted body weight. Is that safe? There is a trial called the PREVENT trial. If your patient isn't an ARDS, it was found to be okay to push it to 8 mLs per kilogram. Maybe even a little higher, but we'll keep it at that. 30 breaths per minute. It gives you a nice minute ventilation, and ventilate for that patient. Troubleshooting the ventilator. So what we've talked about so far is ventilator breaths, the modes. We've started ventilating an hypoxemic respiratory failure patient. We started ventilating a severe asthma obstructive airway patient and a severe acidotic patient. Those are 3 different physiological states that are unique ways to ventilate a patient. Troubleshooting. The ventilator can be used as a monitor too. Not only is it a supportive device, but it can be used to help you monitor the patient. So this is where, and this is what often happens. If you use sucks, you have about 8 minutes before things start to get really interesting, depending on why you intubated the patient. If you used rock, you have about 40 minutes. Both patients are getting appropriate sedation. But what happens after the paralytic wears off? All of a sudden, things get noisy because the patient is in severe distress, agitated, in pain. They're getting procedures. They have to get diagnostics. It's miserable. So then the patient starts to become interactive. And then when you go to the ventilator, it's not going to look like what I showed you because the patient is breathing over the vent. The ventilator is trying to deliver a breath while the patient, so it just causes a lot of misery. So you could use what you're able to see on those scalars to help you decide what's going on and how to respond. So troubleshooting, look at the peak pressure, look at the plateau pressure. You've done this an inspiratory hold in order to get those, and look at the flow to try to see if there's any auto PEEP. Scenarios, peak pressure and plateau pressure. Peak pressure is high, the resistance is high, and the plateau pressure is normal, like that other graph I showed you. What's the differential diagnosis for that? Look at the patient. Patient biting down, there's a lot of secretions, mucus plug, severe asthma. If the plateau pressure is also high, that means now there's actually also a compliance issue. Is there a tension pneumothorax? This just happened yesterday. Is there a main stem intubation? Is the tidal volume too high? Is there breath stacking? So you could look at those pressures and try to tease out what's going on with the patient. I really like this picture because it kind of separates out the ventilator circuit from the patient themselves. High resistance, remember? High peak pressure, normal plateau. Kink in the ET tube, look at the ET tube. Patient biting, there's in misery, they're in distress. Do they need a bite block, some more pain control, some more sedation? Is there a mucus plug? Suction out the airway, problem resolved, a lot of airway secretions, asthma. Do they need a lot more aggressive albuterol? Poor compliance, pneumothorax, iatrogenic, spontaneous, ventilator-induced barotrauma, whatever it may be. Do a lung ultrasound. Is there severe ARDS and edema? Was there a right main stem intubation? It was anxiety-provoking airway, and you kind of just push, and sometimes you overshoot. You get the X-ray afterwards, or before you get the X-ray, you discover based off of the ventilator it may be a main stem intubation. Is there high intra-abdominal pressure? Really bad trauma case, and then auto PEEP. Again, the theme is auto PEEP. Dopes and dots mnemonic. Dopes. Displaced endotracheal tube. Make sure, this is why I'd like to see everyone on an end-tidal waveform capnogram when they're ventilated. Because if it looks like a good waveform, it's in the airway. It's in the airway. The ET tube's there. So that helps you be reassured that it's in the airway. As a monitoring device, also looking at the shape of the end-tidal. If it looks like a shark fin, bad asthma. But you already knew that. Obstructed endotracheal tube, suction out the airway. Put a bite block, sedate the patient, pain control. Pneumothorax. Stacking breaths, auto PEEP, equipment failure, the battery ran out. Empiric treatment, DOTS, disconnect from the ventilator, ventilate, apply oxygen, tube position, adjust the tube, tweak the ventilator, and evaluate for pneumothorax and treat accordingly, like what happened yesterday, which was totally appropriate to treat the pneumothorax. This is a really nice algorithm for just what to do and how to approach picking your ventilator. So you intubated your patient, you did everything perfectly, intubated. Patient looks like you intubated them for hypoxemic respiratory failure. I see people taking pictures. I can give you the reference to the article. It's your EB Medicine. This is a great article. I'll tell you what to read afterwards, just to summarize this. Rebel EM has like 5 posts. It's great. Read, for an hour, good diagrams, read it a couple times. It'll make a lot more sense. And then the EB Medicine 2020 ventilation and emergency medicine. Really good paper. I can send it up. So don't worry. Yeah, I see it. I'm flattered. ARDS, lung protective ventilation is the buzzword. Put that in your note. I'm applying lung protective ventilation. It's an umbrella term. Tidal volume, 6 mLs per kilogram. Titrate your PEEP. Look at the PCO2 and blood gas and pH, and then adjust your minute ventilation. Plateau pressure is too high, go down on your tidal volume. Hypoxemia, go up on your PEEP, FiO2, consider APRV, call for ECMO, potentially. Obstructive physiology, asthma, COPD. Try not to intubate, and then try again. But then you did, and that's okay. Sometimes you do. Same exact thing, only the respiratory rate. Let the patient exhale. Monitor for auto PEEP. Breath stacking, you have to address it. Slow the respiratory rate. You may have to actually sedate them. These are patients that sometimes end up getting on a paralytic for 48 hours just to let them rest. Metabolic acidosis, again, try your best not to. Prevent trial supports you going a little bit higher than that classic 6 mLs per kilogram predicted body weight. Ventilate. It's the exact opposite of this. Respiratory rates of 30 to 35. Compensate for them while you're treating the condition, and then make sure you adjust. Undetermined angioedema or tox. To be honest, you intubated them. The ventilation management becomes whichever mode, almost pick your mode. If they're intubated for angioedema, the airway is taken, and the patient is really calm about it. You're like, oh my God, you're handling this very well. Your Ludwig's angina, you're handling very well. How are you so calm? I'd be freaking out. You can put them right on CPAP pressure support. Right away, just let them breathe on their own. They don't need to be in a controlled. In fact, that may make them more uncomfortable. So their sedation needs may be 0, nothing. Breathing spontaneously. They may be able to ambulate while this is being resolved. Not in the ED, upstairs in the ICU. Summary, we talked about ventilator breaths. We talked about ventilator modes. We talked about ventilating those 3 things, and we talked about some troubleshooting. And I'll send you the references. Let's just do a couple questions, hash it out, and then we're good. 30-year-old male is intubated for status asthmaticus. End-tidal CO2 is 60. The expiratory flow does not return to 0 at end expiration with significant auto PEEP detected. There's no overbreathing because you just intubated the patient, right? What's the best next step? Should you increase the sedation, decrease the sedation, increase the respiratory rate, or decrease the respiratory rate? What's up? Okay, why not increase the sedation? Well, he's not overbreathing. It's whatever you put it in. Let's say you put it in at 16 or 15, right? Yeah, it's not really going to achieve anything because the patient looks like they're pretty passive. The patient's pretty passive. You can't make them any more passive. So you have to do a different thing. Correct. The answer is decrease the respiratory rate. Okay. And are you decreasing the respiratory rate because of the end-tidal CO2 or because of the auto PEEP? Right. The end-tidal CO2 may actually be okay, right? Permissive hypercapnia if they were totally tolerating it. Okay, 30-year-old male intubated for status asthmaticus, end-tidal CO2 is 60. Expiratory flow does not return to zero with significant auto PEEP. The set respiratory rate is 10, but the actual respiratory rate is 25. You intubate with sucks, so it's 15 minutes after intubation. I'm not saying that there's anything wrong with that, but just like that's what happens if you gave him whatever you gave him for RSI, and remember, this is a super sick patient that you rarely want to intubate. 30 minutes later, an hour later, they're not going to be comfortable. They're going to be even more miserable because now they're also intubated with all sorts of things happening, and it's just not. What's your plan? Increase sedation, decrease sedation, increase respiratory rate, or decrease respiratory rate? Increase sedation. Okay. Why not decrease respiratory rate? Yeah, right. He's basically, what mode do you think he's on? On full control or an assist control? I didn't say volume or pressure. He's on assist, right? Because he's triggering breaths. He's triggering 15 above the 10. So he's on some form of assist control, either pressure or volume. 55-year-old male has ARDS due to flu A and is intubated. Oxygen saturation 75% on volume assist control. The tidal volume is 6 mLs per kilogram predicted body weight. Respiratory rate is 16. PEEP is 5. FiO2 is 100%. How would you improve the continued hypoxemia? Would you increase the respiratory rate, increase the FiO2, increase the PEEP, or initiate APRV? Which one? PEEP. Increase the PEEP. Yeah. You can't go up on FiO2, it's 100%. There's no like 110% dial. The respiratory rate is all about minute ventilation. And remember, we're not even talking about the PCO2, and we may accept permissive hypercapnia. What about APRV? It's not wrong, but you haven't really even exhausted the conventional stuff, right? Like just start with the basics. Just go up on your PEEP in your increments of 2 to 5, 2 to 4, 2, and then try to recruit lung. So you're opening up the airways. You're trying to recruit more lung on that PEEP diagram. 25-year-old male, severe metabolic acidosis, intubated, has the following blood gas: pH 7.1, PaCO2 25, PaO2 90, bicarb 4. The bicarb is from the BMP. What is the next most appropriate step in ventilator management? Increase the PEEP, increase the FiO2, increase the respiratory rate, change to APRV. Correct. Increase the respiratory rate. Severe metabolic acidosis. So you have a problem, you intubated, you're picking up on the problem, you're assessing it, and you're coming up with a plan to fix the problem. Not to normalize, but to address it, right? Let's play the game of what mode is this? Name that mode. What mode is this? Why? You know, you're right. I hope I didn't. That's most of the time going to be an answer. No. You're right. It is a volume controlled breath. What else is showing you that it's a volume controlled breath? Square waveform inspiration. What else? Yeah, and I don't mean for it to always sound like a shark fin, even though I use shark fin, but it ramps up. It doesn't go straight to some number and then go. There's an elevation. And what would you do if you wanted to get a plateau pressure? And can I get the answer right there? Inspiratory hold. That's right. So pressure, flow, volume. Okay, what is this? Why? Why? It's a square waveform pressure, so it's constant. You're controlling for that with a decelerating flow, and the variable is going to be the volume. What is this? Name that mode. What? Some people are saying stuff, and then other people are nodding in agreement or disagreement. Someone's got to yell it out loud. PRVC, that's correct. It's basically a pressure control, assist control, only the volumes are the target, because the PCAC is adjusting on a minute to minute by applying a different pressure to achieve that volume. But it's actually a pressure control mode. Just it's like a smart pressure control mode. And then what's this? Correct, CPAP pressure support, totally spontaneous. What mode is that on the left? Name that mode. Volume, right? It doesn't even say the mode on top, right? You just looked at the screen. That's the point I'm trying to make. What's the mode on the right? Pressure, right? Square waveform, decelerating flow. Pressure, flow, volume. Volume assist control, pressure assist control. What mode is this? APRV, right? But it also has a kind of look to it. All right. Thank you very much. Any questions? Yeah. How soon after? So the question is how soon after plateau pressure? You can check it pretty soon. You may want to give the system a little bit of time to equilibrate. So when you change, let's say you change a tidal volume from, let's say, 450 to 420, maybe give it like a little time to just equilibrate, and then you could check it. There's no like hard, fast rule, and then you can do an inspiratory hold. You don't want to do too many because essentially if you keep doing it every 5 seconds, you're kind of doing like a little APRV. You're keeping it at inspiration, letting go, inspiration, letting go. And you just want to make sure the patient can tolerate all these checks. So give it some time to equilibrate, let's say 15 minutes, and then check. Yeah. As soon as you want them to achieve a certain goal. So if they're persistent, let's say a patient comes in with that X-ray, bilateral, fluffy infiltrates, it's not cardiogenic, even if it's cardiogenic, actually it doesn't matter, but it's hypoxemic respiratory failure and they're dangerously low 75 despite FiO2 of 100%, PEEP of 20, 24, and pretty passive, very passive. And it seems like you have to ramp that up. The time frame to, let's say, prone, we don't really have the resources to do that. To do nitrous oxide, again, so the next move is to work with what you have, the ventilator. You can start right then and there. And what you're doing by doing APRV as opposed to the conventional is you're keeping the airway pressure, the pressure in the thorax, high longer. And that's the difference between that APRV and a conventional mode. When I use the term conventional mode, I'm referring to PCAC, VCAC, PRVC, CPAP pressure support. APRV is just keeping the airways, the alveoli open for a little bit longer with the goal of recruiting. And you should wait. You don't have to make a change every 5 minutes. Apply the APRV and give it 20 minutes, 30 minutes, an hour, and see the change that you're doing. Go ahead. Oh, I just like anecdotally, it had nothing to do with the ventilator management, but just to make it relevant that this stuff happens all the time. Patients on a ventilator, and then something else happens, and there's alarm system. So it had nothing to do with the ventilator. Everything was done right, but just an anecdote. Actually, I heard it was a case of Dr. Soldier, and really messed up. No, I'm just kidding. Yeah. Next question. All right. I'll send you guys the references, and I'd say let this sink and then read those, and it'll make more sense, and then just gain as much exposure as possible during your ICU rounds and your CCT rounds and all that. Okay. Thank you.